Leukemia is defined as a malignant neoplasm of blood-forming tissues, including bone marrow, spleen, and lymph system. It's characterized by an abnormal proliferation of immature WBCs, or leukocytes, and their precursors that infiltrate bone marrow and peripheral blood, as well as bone or organs and tissues. So there are types 4 that we identify, and they're just to define the type for treatment. Nursing interventions are very similar between the types. There's acute lymphocytic or lymphoblastic leukemia, which is ALL, and it's most common for children between 2 and 10 years of age, and it also occurs in middle age and older adults. We see abnormal leukocyte cells that resemble immature lymphocytes or lymphoblasts, and they are immature lymphocytes that proliferate in the bone marrow. AML, which is acute myelogenous or myelocytic leukemia. We have immature granulocytes which proliferate and accumulate in the bone marrow. We usually see this in people who are over 50 years of age, so the rate increases with age. And this there's also a myelodysplastic syndrome, which is a hematological disorder of the bone marrow and is referred to as pre-leukemia, and that can progress to AML. There's chronic lymphocytic leukemia, and that's abnormal incompetent lymphocytes that proliferate, accumulate, and spread to other lymphatic tissues. This is a more gradual onset, and it's more common in men and occurs between ages 50 and 70. And then finally, chronic myelogenous leukemia, and we see abnormal stem cells that lead to uncontrolled proliferation of granulocyte cells, and there's a marked increase in the circulating blast cells, and that leads to leukostasis and intracerebral bleeding or hemorrhage. Yes. So they're categorized by the different types of WBC that are affected. It can be acute or chronic. Obviously, acute is a much rapid onset, and chronic is something that is managed over time. So the pathophysiology behind that, actually, let's talk about the risk factors to begin with. There are some lifestyle risk factors: smoking, alcohol consumption, dietary or nutritional factors, and they've identified that a decrease in intake of B vitamins and iron can increase the risk. Occupational and physical environment risk factors, such as exposure to chemicals, and the research identifies benzene and arsenic as factors, as well as pyridine and aniline dyes. And the risk factors for hematological cancers are iatrogenic agents such as immunosuppressants and chemotherapeutics. So individuals who have had chemotherapy and immunosuppressants are also at higher risk for developing a leukemia. And also some other risk factors for anemia that can lead to the advancement of leukemia very further on are socioeconomic factors such as poverty and inadequate nutrition. So those are other issues. So like I said, the classification of leukemia: acute is rapid onset. It progresses to a fatal termination within days to months. This is the all-consuming one that you hear about. It's common among children and young adults. And then the chronic leukemia is a gradual onset with a slower, more protracted course, and is common between the ages of 25 and 60. Signs and symptoms that we see in patients who have leukemia: ulcerations of the mouth and the throat. We can also see fevers, pneumonia, septicemia, altered leukocyte count between 15 and 500,000, anemia, fatigue, lethargy, bone and joint pain, bleeding gums, ecchymosis, which is nosebleeds, petechiae, retinal hemorrhages, weakness, pallor, weight loss, hepatomegaly, splenomegaly, so they have enlarged spleen and an enlarged liver. They may have headache, disorientation, and convulsions could arise if they have the bleed in the head. So our nursing assessments, when we have a patient, we're going to assess breath sounds, activity, tolerance, pain, nutrition. We're going to look at their oral mucosa. We're going to check for enlarged organs, spleen and liver specifically. We're going to look for enlarged lymph nodes. We're going to look for any signs and symptoms of infection. And that's common in acute leukemia, but the signs and symptoms may be absent because they're neutropenic, which is a decrease in the neutrophils. We're going to look at their labs, hemoglobin, hematocrit, platelet count, granulocyte count. Those will drop consistently, and especially during chemotherapy. And typically we will see if they're being treated with chemotherapy, these labs will bottom out around 5 to 7 days after initiation of the chemotherapeutic agent. Let's see, what else do I want to tell you about this? So we're going to do cultures if infection is present, and we'll do a bone marrow biopsy, and we're going to talk about that later. What would our nursing interventions be? Well, we're going to definitely check for signs and symptoms of bleeding. Like I said before, petechiae, bruising, and actual bleeding itself. Any signs and symptoms of infection, change of vital signs, chills, neutropenia. We're going to feed these people a soft diet with increased calories and increased vitamins. And we are going to also check their mouth and give them analgesics to control their pain, antiemetics for the nausea, chemotherapy if we need to use that. Large doses of chemo are often given one at a time through induction for certain types of leukemia, such as AML. They may need a bone marrow transplant. I'm going to talk about that later. And we want to protect them from infection. So if we need to use neutropenic precautions, we must have meticulous hand hygiene, provide oral hygiene after all meals and bedtime because they have the stomatitis, and the sore mouth can occur from the chemo. We're going to screen all visitors and staff for colds and infection, monitor their vital signs every 4 hours. No fresh fruit, no flowers, no plants, nothing in standing water. We're going to change their intravenous tubing per policy. It's recommended every 24 hours, but it's whatever the policy is of where you're working. And we're going to avoid medications that would mask a fever, such as Tylenol or ibuprofen. And then if there is an infection, we're going to be administering antibacterial, antifungal, or antiviral medications as prescribed. So we're going to teach them preventative or interventional skin and oral care. So we may have to actually use some type of skin care on them. We're going to make sure that we turn and position them, obviously. Give them blood transfusions if needed, and administer medications and treatments as ordered. If they are in chemotherapy, we're going to monitor them for nausea, vomiting, diarrhea, the stomatitis, the alopecia, skin reactions, bone marrow depression. They could possibly have a radiation or radioisotope therapy as well. So we're going to teach our patients about these issues and the family members. Continuing in the nursing process, we're going to evaluate those interventions and go back and repeat this all one more time. Now, a bone marrow biopsy, which provides actual bone marrow tissue for definitive diagnosis as to the type of cancer we're dealing with, the type of leukemia, is done in either the OR or a procedural suite. There's strict aseptic technique. So prior to that happening, as a nurse, we want to make sure that there's informed consent. It's typically done in the iliac crest or in the sternum, so a flat bone. It is a painful procedure. We're going to tell the patient it's going to hurt. We'd like to pre-medicate them, talk to the doctor about getting a pre-medication for that patient. They will have a local anesthetic, and then they will go in with a needle and aspirate the marrow. Post-procedure, we want to make sure that we're applying pressure. If there's bleeding, a sterile dressing is put in place. Complications that could occur are osteomyelitis and further bleeding. If further bleeding occurs, of course, we're going to be holding pressure on that and calling for assistance and letting the physician know. Another complication is internal organ puncture related to location or technique, and I've never seen that happen, but it is a possibility. Here's a little bit of information about a bone marrow or stem cell transplant. Once a donor has been identified, and the best donor is probably a full sibling because you came from the two parents and have similar DNA. So the collection is done in the operating room from the patient's donor. The donor goes in, they aspirate bone marrow from a large flat bone, typically the iliac crest or the sternum. It's painful. They put them under a general typically to do this. That bone marrow then goes off to the magic place called the laboratory, where the stem cells are concentrated and prepared, and they are spun out in a centrifuge, and then they're frozen. So there's cryopreservation, where the bone marrow or the blood, if it's a stem cell, is frozen. It is how it's preserved, and that keeps those cells alive until it's time to give it to the patient who's going to be receiving those cells from the donor. Now, whatever they're going to do, however they do, if it's bone marrow or if it's stem cells, it is then infused into the patient as an IV. Patients think they're going to get, if they're having a bone marrow transplant, it's going to be injected into their bone. It is not. It is spun out and it is put in plasma and goes back into the patient through an IV peripherally. So prior to that, the patient is treated with chemotherapy to kill off all the offending cells, and then the transplanted cells are placed in either bone marrow or stem cells, and it's infused through an intravenous peripherally, and the patient gets those thawed cells. So that's how it's given. That's how that transplant occurs.